Good afternoon and welcome. We will be starting shortly. Thank you for joining us today. We want to make sure we give people time to join us before we start the webinar. I see we have a lot of people joining us today, so we hope to share some useful and important information with you. And so we take advantage of our time. I will go ahead and start this process. Please note that the webinar will be recorded and shared at a later date once it is posted to our website. But welcome. My name is Angela, and welcome to the Pulmonary Hypertension Association's live webinar, Discovering New Pulmonary Hypertension Therapies. Before we get started, I would like to take a moment to thank Johnson & Johnson Innovative Medicine and Bayer for their support of our PHA Connects program. Next slide, please. Also, I'll take a moment to share, as a nonprofit membership organization, PHA relies on the support of its members to help fulfill its mission. Please consider joining PHA and joining our global network of PH patients, caregivers, donors, and healthcare professionals, and enjoy access to future PHA events, webinars, and publications. So if you are already a member, thank you so much for your support. If you're not a member, please consider joining and reach out to membership@phassociation.org or visit phassociation.org/join. Thank you. Next slide, please. And again, before we get started, there are a few programming notes that we would like to mention. We will have the Q&A immediately following our presentation from our panelists. There is a Q&A button at the bottom of your toolbar to submit any questions throughout the webinar, so you don't have to wait to the end to submit your question. However, please be mindful and not share any personal medical information in these questions. You should direct those personal questions to your healthcare team. And lastly, a post-webinar survey will pop up at the conclusion of the webinar. It should pop up in a new window. Please take a moment to complete that survey. That will help us figure out what you would like to see in the future in webinars like this one. Next slide, please. So now we're going to get started and share this important information. I will turn it over to my colleague, Elizabeth Joseloff, the Vice President of Quality Care and Research, who will introduce our panelists and moderate the webinar for today. Elizabeth?
Thank you, Angela, and welcome everyone. We're really excited for today's webinar. I have the pleasure of introducing our speakers for today. Dr. Sandeep Sahay is Associate Professor at Houston Methodist Hospital. He's a co-director of the PHA-accredited PH Care Center program at Houston Methodist. He's also a member of the PHA Scientific Leadership Council. I'm also happy to introduce Dr. McLaughlin, who is the director of the PHA-accredited Care Center program at the University of Michigan in Ann Arbor. And Dr. McLaughlin is a past chair for the Scientific Leadership Council for PHA and a member of the Distinguished Advisory Committee for the SLC. I will now turn this over to Dr. Sandeep Sahay, who will begin our program.
Thank you, Elizabeth, and thank you, PHA, for the opportunity. I'm Sandeep Sahay from Houston Methodist Hospital. These are my disclosures, nothing relevant to today's talk. Next slide. So today I'm going to talk about some newer therapies and what the mechanism behind these upcoming newer therapies are, and what do we understand about disease-modifying therapy, and why do we really need disease-modifying therapies. I will discuss some background information about some mechanism of these therapies, and the rationale. And then after that, Dr. McLaughlin will go into more detail about newer upcoming therapies and studies. Next slide. So whenever in the process of drug development, it is very important we need to understand what our patients really want. I mean, in an ideal situation, we would like that if we can have mechanisms to prevent a disease development, or we could identify people who are at risk to develop disease. PH is a challenging disease. It's not very straightforward answer here that how we can prevent the disease. However, in certain patient population, we know who are the patients who can develop the disease, but it's still challenging to prevent the disease development in PAH. Now, if patients have developed the disease, then ideal situation would be if we have a cure for disease. Again, we are working very hard. Our research is going on the clinical side, basic science. It's a very aspirational goal for PH because it's a complex disease. And so far, we have not identified a curative agent, but we have definitely made some success in treating the disease. Now, if we are not able to prevent or identify the cure, then we should identify or invest our research and efforts in identifying therapeutic agents where we could delay the progression or decline, because this has direct impact on our patients, care provider. This can delay the disability and make our patients live independently as much as they can. And then in the last but not the least, it is very important that our therapeutic agent should be able to relieve their symptoms to the best degree possible and improve their feel and function, and eventually, of course, to survive them longer. Next slide. So here I'm going to highlight the definition of disease modification. What do we really understand by that? The disease modification means that a therapeutic agent or any intervention should have an impact on the underlying pathophysiology of the disease. It should affect the drug should affect the disease at the cellular level so that it can impact the trajectory of the disease progression. So as highlighted with these 3 points, again, should affect the underlying pathophysiology, should have a sustained clinical benefit, should be able to distinguish this from the symptomatic treatment. And again, this terminology, disease modification, this is actually designated by the regulatory authority. Like in the United States, it's generally FDA. In Europe, it's European Medical Agency. These are the agencies which identify or designate drugs as disease modifying agent. Next slide. So for regulatory purpose, disease modification is defined as a disease modifying effect is when an intervention delays the underlying pathological process and is accompanied by improvement in clinical signs and symptoms of the disease. Now, this is different from the symptomatic treatment, which may improve the symptom but does not affect the long-term survival or outcome in the disease. Example is use of diuretics in PH. As many of you know that when we treat pulmonary hypertension, we use PAH medications, which target particular pathway in the disease. But then we also use diuretics, which can relieve the symptoms, but they do not directly affect the disease pathways or specific pathways. Next slide. Now, and another important concept in reference to the PAH particularly is that what medication we would consider as disease modifying and where it should act, because PH, as you can see on the red box on the left side of the slide, highlights the involvement of the pulmonary vasculature, or because it's a disease of pulmonary artery and capillaries. So what drug should be considered as a disease modifying? Where should it be targeting? A drug which targets the pulmonary artery or the capillaries should be considered as disease modifying. Then the question comes eventually in pulmonary hypertension, the bad outcome is because of the right ventricular or right side of heart to fail. That's when patients have poor outcomes. Should a drug affecting the right side of the heart be considered as disease modifying? Um, this is currently debatable, but generally not, because the pathology is in the pulmonary artery. So the drug, to define it as a disease modifying, should act on the pulmonary vasculature or the pulmonary arteries. And then lastly, if a drug just helps with the symptoms, that will not be considered as disease modifying. Next slide. Now, the big question is, why do we really need to talk about disease modification, and why do we need a disease modifying drug? And I think the answer lies in these two these survival curves. If you look at the bottom one, which is the blue curve, it's from one of the first US-based NIH registry, and you can see the 7-year survival in PH was roughly around 30%. And the top one is with the Reveal registry, which is around 66%. So definitely we improved, but again, 7-year, 66% survival is also not where we would be satisfied or we would want to improve further. So definitely we have made some progress, but we need to do better than this by finding better treatment agents. Next slide. So this is just to highlight what our current three pathways are, and I think many of us are familiar with them. On the left side, there is endothelin receptor pathway, then prostacyclin, then nitric oxide. And I'm not going to go into details of each and every drug, but I think most of us are familiar with these three pathways currently, which we use in the treatment of PH. And all these are PH-specific therapy because they target in some way the pathophysiology of the disease. Next slide. Now, as we know that there has been successful phase 2 and phase 3 trial with another agent, and now I'm just trying to highlight that how in future our treatment is going to look. Initially, we had the three pathways, which you can see on the right side of this figure, this diagram. But on the left side, I'm talking about an activin signaling inhibition, which is now the fourth pathway in the treatment of PAH. And as you see, this figure in the bottom shows you how the drug molecule binds with the activin receptor to decrease the signaling on the activin receptor, which in the downstream reduces the smooth muscle proliferation, which is one of the hallmark feature in the pulmonary arterial wall. So this is how this newer pathway works, or these drugs targeting this newer pathway works. Next slide. So to mention, this is the phase 3 trial of sotatercept, which we all are familiar with, that this drug is currently with the regulatory authorities for approval, but has shown significant findings in the phase 2 and phase 3 trials. Next slide. So here I wanted to highlight the primary endpoint of this phase 3 trial, which was 6-minute walk distance. And as you can see, the yellow bar on the top was the patients who received the drug, and the gray bar in the bottom were those who were on placebo. And I think this is very much self-explanatory. You can see that how the patients who received the drug responded very well, and their walk distance significantly improved compared to those who received the placebo. Next slide. This is a little longer term survival, around 75 weeks, those participants in the trial, again, showing you can use non-fatal events, means the disease worsening as defined in the trial, or hospitalization, or needing parenteral prostacyclin. Those events, you can see the patients who took sotatercept had much less compared to those who required who were randomized to placebo. So the patients with sotatercept did much better in terms of these events as well. Next slide. This is about the side effects, and wanted to highlight that the drug also has some side effects which was observed. I think the most important was about the bleeding risk. It did increase bleeding risk in some patients, as you can see here, around 20% of patients with sotatercept versus 12% those who were placebo. The other thing which was noticed was a drop in platelets, roughly around 6% to 2.5. In certain patients, around 10% patient, telangiectasias, which are the abnormal blood vessel proliferation, which can happen in drug, which was observed in around 10% versus 3% in placebo. Apart from that, the drug was very well tolerated. If you look at the discontinuation of drug was much lower in this study, just around 1.8% versus 6% of placebo. Next slide. This is the long-term use of sotatercept. And again, these findings, again, this study is ongoing as of now. So it's not the final data, but it clearly shows that even on the long term, the effect is very much sustained. The green bar is at 24 weeks in the long-term study, and this is at 1 year from the beginning of the long-term study. And you can see that how the improvement in 6-minute walk distance on the left side, then improvement in NT-proBNP and the functional class. Overall, there was a sustained response observed in 1 year duration of this study, and patients were able to achieve the low risk and stayed in the low risk. So I think we will learn more about the study as the time goes on, how these patients do in further period. But so far we have data around for approximately 1 year, and they've been doing really well. I think with that, I would like to end here, and I will hand over to Dr. McLaughlin. Thank you.
Great. Well, thank you so much, Dr. Sahay. It's a pleasure to be here with you as well. And obviously, there's a lot of excitement about all the new therapies that we have available. And so I want to just expand a little bit on some of what you've already heard and maybe talk about a couple of other things. Certainly at a meeting like this, we don't have the time to talk about every single therapy that is being developed for pulmonary hypertension. And listed on this slide are some of the other therapies that are undergoing potential clinical trials, or at least initial trials to treat pulmonary arterial hypertension. And I think this is really exciting because, as Dr. Sahay mentioned earlier, we've been doing this for 2 decades now, and we've had the same 3 pathways, and that's great. I think patients are doing better. It's nice to have all those options, but we still lose far too many patients to this disease. And so having additional therapies is going to be very, very important for many patients. Now, on the next slide, we talk a little bit more about the STELLAR study. And Dr. Sahay mentioned this a little bit, and I just want to expand on it in a little bit more detail. So this was a randomized controlled trial looking at this novel therapy, which he so eloquently described, sotatercept, which is an activin signaling inhibitor, in patients who were already on therapy for pulmonary arterial hypertension. So I think that's really important to remember the patient population in whom this drug was studied. It was patients who still have functional class 2 and 3 symptoms. So some amount of shortness of breath, despite other therapies. And most of the patients in this trial were on multiple other therapies, including about 40% who were on prostacyclin infusion therapy, so very aggressive medical therapy. And those patients were randomized to either placebo or sotatercept. And the primary endpoints, which were discussed already, were measured at 24 weeks, and there was an improvement in 6-minute hall walk, time to clinical worsening, and many other endpoints. So a very successful clinical trial. Now, Dr. Sahay showed you some of the data that was published with the initial paper in the New England Journal, but on the next slide, we're going to go into some more of the data that was published just this past fall. So this study looked at right heart cath at the beginning and end of the 24 weeks. And I think it's really important to see the changes that happened. There's about a 14 millimeter reduction in the mean pulmonary artery pressure in the patients who received sotatercept. So that's pretty impressive, like on top of all that other therapy. There was not so much a change in what we call the cardiac index, the amount of blood that your heart pumps through your body every minute. And there was a significant change in that number, that resistance number, that pulmonary vascular resistance, which takes into account pressure and flow. So I think this is important because a lot of patients who are on all the other FDA-approved medications, even though they're better, a lot of them still have high pressures. And this drug affects the mean pulmonary pressure more than any other drug that we've studied to date. On the next slide, you see some of the changes that occurred in echo, the ultrasound of the heart. So we can get some nice pictures of the right ventricle and how the right ventricle is coping with that high resistance. And so when patients get worse from pulmonary hypertension, it's not because their pressures go up and up and up. It's because their right ventricle gets tired of pushing blood through that high resistance. And so the squeeze is not as robust. And so the echo can measure some parameters of how the right ventricle squeezes, and demonstrated that there was better squeeze. And the fancy words are TAPSE or fractional area change, but measured that the right ventricle was coping better with that high resistance, which is very important as well. On the next slide, we see some of the other clinical trials that are going on. And I think this is important because what we learned from trials is how a drug affects a certain population. And so the STELLAR population, which is the trial that's been submitted that will likely lead to FDA approval of this drug, is in patients who've had the disease. Many of them have had the disease for many years, 8-9 years on average, and who are on many other therapies. And so we see that it works in them. But there are 2 other trials going on to look and see if the disease might work, or the drug might work earlier in the course of the disease. So that's Hyperion, looking at patients who still have an intermediate or high risk score within the first year of therapy, and would instituting therapy earlier help them? And then Zenith, which is another trial that is looking at the later stages, the patients who are really super sick, the patients who are awaiting lung transplantation, don't have many other options. So it's looking at that. Now, I do see that there are a couple of questions about sotatercept in the chat. So I'm going to go ahead and try to take a couple of them while we're on that topic. So one of the question has to do with, well, will you be able to come off other meds if you go on this therapy? And so that's a really important question. It's a question that many patients want to know. Obviously, many patients are on very complex therapies, and gosh, wouldn't it be great to get off of a pump? And we don't really know the answer to that. Remember, this was a 24-week trial, and the goal of this trial was to evaluate sotatercept. So we didn't really want a lot of changes in the other medications. So we haven't answered that question in the course of a randomized controlled trial. Dr. Sahay mentioned the Soteria study, which is the open label extension study. And, then all the patients, who've completed the 24-week placebo-controlled study go into this open label extension where they're assured of getting drug. And, people get usual care in that. And so there have been some patients in that open label extension study who've had their doses reduced or have even come off some of the other medications. And so that is something that needs to be discussed on a case-by-case basis with your doctor based on how you've responded to the therapy. I also see some questions about the bleeding events. And I think this is really important because it's easy to get so excited about a new therapy and look, this works. And, but every drug has side effects. And so we did learn that there was a higher rate of bleeding in the sotatercept studies. Most of the time it was minor, nosebleeds, that sort of stuff. But there were a handful of more serious bleeding events. And so this is one of those things that we always need to chat with the patient about. Whenever you talk about adding a medication, you need to talk about the potential benefits and the potential risks. And so you need to kind of evaluate that in every individual patient. And there may be some patients who have really bad pulmonary hypertension, and maybe they've had a history of minor nosebleeds, and you say the benefit outweighs the risk. There may be patients whose pulmonary hypertension is pretty well controlled on oral therapies and has a history of GI bleeding, and there might not be a lot to gain, but there might be a lot of risk. And so you might say maybe that's not the right patient for that drug. So the shared decision making, I think, is something that really needs to be taken on an individual patient basis. And then the next question I actually have a slide for. So if you want to advance the slide, this is when we expect to hear about the approval of sotatercept. So the FDA has what is called this PDUFA date. And so this means the date by which the FDA has committed to complete its evaluation. And so, so it should be by this date. Every once in a while we hear the FDA has staffing issues and they miss it by, a little bit of time. But in general, we expect to hear by March 26th as to whether or not the FDA is going to approve sotatercept. And if they approve sotatercept, what the details that they'll put around the package labeling is, which is very important. Especially when it comes to insurance reimbursement. And I'll just remind everyone that this is a subcutaneous, so under the skin injection like insulin that is given every 3 weeks. It looks like there was a question about that too. So why don't we move on? So we're really excited that sotatercept might be available soon. But there's lots more in development. And, every time something hits, it's always good to have other options. And so there are other activin signaling inhibitors in development. And this product here, it's just got a name of KER-012 at this point, is another activin signaling inhibitor that has some minor differences in the properties of what it blocks and what it doesn't block, and may have less effect on some of the blood count issues that we've seen in with sotatercept. And it's been studied in preclinical, so in animal models, and a phase 1 trial. And on the next slide, you can see that there is what's called a phase 2 trial of this drug that has actually started. Actually, coincidentally, my site had their site initiation visit for this trial yesterday. So we'll be up and enrolling very shortly here. It's a phase 2 trial is that first step, is really trying to prove that proof of concept. And usually what we're looking at in a phase 2 trial, the primary endpoint is the heart cath numbers, is what the drug does to hemodynamics. And also what dose of the drug works and what are the side effects. So this phase 2 trial is looking at 3 different doses of the product KER-012 or placebo, and looking at pulmonary vascular resistance as the primary endpoint. So I think there's going to be about 90 patients in this trial, and it'll be a worldwide study. Next slide. And there are other exciting studies going on. So this one is with an inhaled version of imatinib. So many of you may have read case reports, quite a while ago about a patient with advanced symptoms on everything given imatinib, or the brand name is Gleevec. It's used for some type of cancers. And so there are a few case reports of patients doing well. There was a clinical trial that showed that in patients with pretty substantial pulmonary arterial hypertension, that there was an improvement in pulmonary vascular resistance, but the drug wasn't very well tolerated. A lot of GI side effects, a lot of people dropped out, and even some episodes of bleeding in the brain. And so it didn't get approved. It didn't get further studied. But there have been some companies, and including the company that's sponsoring this study with inhaled imatinib, that have said, well, the drug theoretically is very good for the pulmonary vasculature in someone with PAH. Can we deliver higher doses to the lung that affect the lung blood vessels, but don't get absorbed into the body to cause some of the other side effects. And so this is an inhaled therapy that's being studied in a clinical trial. It's kind of emerged what we call phase 2/3 clinical trial, the IMPACT study. So the goal of the first part of the trial is to look at some different doses of the drug to see what it does to that hemodynamic number, that heart cath number, that pulmonary vascular resistance, pick the right dose, and then go into the phase 3 trial. So on the next slide, you see the design of that trial the enrollment of those patients. So functional class 2 to 4 patients who are on background therapies. The next slide, you'll see the first part of the trial is looking at phase 2B, looking at multiple different doses, and is going to look at PVR. They've enrolled that first part of the trial. They should have the information sometime this summer about the effects on PVR and what the right dose is. And then they'll go straight into the phase 3 with that right dose. And the phase 3 study is the bigger study looking at 6-minute hall walk as the primary endpoint. So that's inhaled imatinib. On the next slide, we see some of the phase 2 data from inhaled seralutinib. So this has already completed its phase 2 trial. Again, looking at those heart cath numbers, the pulmonary vascular resistance, and demonstrated there was an improvement in that pulmonary vascular resistance in patients with PAH on all these background therapies that received the seralutinib medication. And the effect here looked more prominent in the patients who were sicker, the patients who had functional class 3 symptoms, so more advanced shortness of breath. So after this positive phase 2 trial, the next slide, you'll see the phase 3 trial, the trial to lead to FDA approval of seralutinib. And so this is, again, another 6-minute hall walk trial over a long period of time, over 24 weeks, where patients who are randomized to the drug or placebo in addition to their background therapy. So that study is also ongoing. Next slide. So where do we land? You know, we have all these treatment algorithms, and you know, it's wonderful to have as many options as we do. But you know, some patients still don't do well despite the therapies that we have. And so this was an article written by a group of people who said, you know, gosh, you know, this is what we expect to be available next. How do we think sotatercept will fit in to the treatment algorithm? And so on the left, you know, you see kind of that initial decision based on how sick the patient is. And remember, we told you that the sotatercept trials took patients who were prevalent, who already had the disease, who were already on therapy. It didn't study brand new patients. So we don't have sotatercept there on the left. Because there's really no evidence to use it that early on. Doesn't mean it won't work. We just haven't done such a clinical trial. So the recommendation here is to give patients usually dual oral therapy unless they're at very high risk, in which case they get the dual oral therapy with the endothelin receptor antagonist and the PDE5 inhibitor, as well as a pump, and then follow them up. And then if a patient is at low risk or intermediate low risk, you know, maybe we continue their therapy as it is, but maybe if they have, you know, really bad heart cath numbers, or if they have a right ventricle on the echo that looks stressed, maybe there would be some thought to add sotatercept there. However, if the patient is at intermediate, high, or high risk still, one should think about adding either sotatercept, or if they're not already on it, a parenteral prostacyclin therapy. So, you know, we have to see more about what the label looks like, what the FDA says, and, you know, I'm sure there will be many more conversations about the place of sotatercept in the treatment algorithm and in how we all use it. So if we go to the last slide, to sum up, despite our advances in therapy, many patients do not meet our low risk criteria. Many patients still don't do as well as we would like them to do. So it's great to have more therapies. We also would love to have advances in therapies that make care more convenient for patients. I grew up with epoprostenol with Flolan. It was like it was the only drug that was available for the first 5 or 6 years of my career. So I have the utmost respect for it. But most patients wouldn't want to be on it if they didn't have to. So are there ways that we could make care more convenient for those patients? And it's really exciting, I think, for all of us, for the providers and the community of patients, to have a new therapy that works in a different way, that looks like it's very effective, meeting the primary endpoint and 8 of the 9 secondary endpoints in the study. And, also very exciting is that there are a number of other therapies that are undergoing clinical trials. And so choices are a good thing. I remember one of the first nurses that I worked with, choices. It's good to have choices because everyone is going to need something a little bit different. So I think that ends the slide presentation. And Elizabeth, we perhaps can go to the Q&A section.
Great. Thank you both so much for a really informative presentation based on the number of attendees for this webinar, as well as the number of questions that we've received both ahead of time and also during the presentation. There's just a lot of interest and excitement with the new therapies that are in development and coming down the pike. So we will jump right into some questions. And please, as a reminder, there's the Q&A button in the Zoom. Please keep sending in questions if you have them, and we'll do our best to get through as many as possible in the remaining time. So I will kick it off with a couple questions that were submitted ahead of time for this webinar, and then we'll move over to the Q&A that are submitted now. So one of the questions that we received both during this webinar, but also ahead of time, was related about how long it would take once a drug becomes FDA approved to have it be available to patients, and then questions along the lines of how a patient would go about figuring out whether this new drug was right for them and when's the right time to add on or switch that new medication. So I will, whoever would like to jump in and answer that, I'll just turn it over to you all.
Let me start, and then Dr. McLaughlin can add further. Well, so the first part, I think it's going to be variable when it will be available to patient, depending on the insurance companies also after the FDA approval. It might vary from state to state, but I guess no definite deadline after the approval, how soon it can be. But I would expect in 4 to 6 weeks, we should start seeing it to be available to patients. And then also it depends on the specialty pharmacy roles also. So I think those factors will play a role. And what was your second question, Elizabeth, about the...
So how to figure out, so the question is basically for helping a patient figure out whether this new drug treatment might be right for them, and then what would be the right time to make that switch, or either to change medications or add on to their current therapy.
I think Dr. McLaughlin very nicely in her presentation showed some slides on the treatment algorithm and also on the risk status. And definitely if you are not in the low risk status and your right ventricle is not looking good on the echo imaging, one should consider the drug. I'm imagining that you are assuming that you are already being treated with 2 or 3 therapies, and despite of that, you are not at goal. Certainly. But again, this is an individualized decision between the patient and their physician, whoever is treating them. So definitely it should be brought up in the discussion as to when is the right time to introduce and you are the right patient for that drug. I think Dr. McLaughlin, you have something to add on this.
No, I think you did a nice job. I guess I would just want to temper expectations about when it will be available, because all the insurance companies are going to have their processes. They're going to need to review it and decide, who they're going to cover it in and that sort of thing. And so there may be some insurance companies that already are very familiar with pH, that it gets on their formulary early. There may be other insurance companies that need a little bit more time. So I think that's going to be highly variable. Sometimes we do see assistance programs or compassionate use programs from drug companies to help bridge that time. The thing that's very important for those sorts of programs is that the drug company needs to be very clear that the patients they're assisting meet the criteria in the label. It needs to be very clear on label use. So that's why, like, what is in the FDA label is very important for those sorts of patients. We've been here before, and so there's probably going to be a variation depending on insurance companies.
So while we're on sotatercept, I'll just ask a couple more questions about that, and then we'll go more broadly in some of the questions. What is it going to look like to receive it? Will a doctor need to provide me sotatercept in a medical setting in the clinic, or will this be medication that I'll be able to receive at home?
So this is another good question, and another question that we can't really answer until the FDA has approved the drug and decides what goes in the label. What we do know is that during the clinical trial, that the patients received their injections at the sites. And so sometimes the FDA says, well, that's how it was done in the clinical trial. That's how we proved the efficacy and safety, how effective and how safe the drug is. You have to do it that way, which would be really difficult for a lot of patients. And so we've, certainly given that feedback to the company that's developing the drug. And so they've done some additional trials, just what they call human factor studies, like can, an average intelligence adult be taught how to do this without making mistakes? So there's some data from that. And then during those open label extension studies, we had some patients that were eligible for home administration who gave it to themselves at home. And so that question really is all that data about home administration convincing enough to the FDA where they say, okay, we believe home administration can be done safely because there's some things that need to be monitored and effectively. And so we will not know what the FDA says about that until they approve it and we see what's in the label. I will say that there's I suspect the people who make the company that makes it is working with all the specialty pharmacies that you're familiar with, and will do everything they can to make it as easy as possible on the patients.
Great. I think I'll switch over to some of the questions in the Q&A because there's quite a few in there. One of the questions is will there still be a need for lung transplantation for patients if they are on these newer therapies that are coming through?
Well, it's an interesting question, but again, it all depends on first the introduction of the drug to the patient, at what stage, how advanced the disease is, how good or bad the right ventricle looks like. And I think another very important factor is to consider is how you respond to the treatment. I mean, if you nicely respond and you tolerate the drug and without any complications, and you stay on it longer, definitely I cannot say that it may not be needed, but it can certainly delay the need for transplant. But if you do not tolerate or get issues or some complications, then certainly that will become challenging. Again, it will require regular clinical assessment after introduction of the drug, and then it's dependent on your physician and, of course, the nature of your disease, how aggressive that is.
Okay, so there's a number of questions that relate to associated diseases with pH, and these, such as autoimmune diseases, and whether these new therapies would be appropriate for that, and what experimentations and studies need to be done in order to determine whether these new therapies would be appropriate for associated diseases.
So in terms of associated diseases, some of them are included in entry criteria in clinical trials. So that patients with connective tissue disease were included in the sotatercept trials. There were actually a little bit less of them in terms of percentage of the population than we've seen in other trials, and there are probably reasons for that. But they were included. Also, patients who had had holes in the heart that had been repaired for more than a year that were included. So a number of other group 1 patients were included, and usually the labeling goes for group 1 in a study like that. So if the FDA does what they've done in the past, the label will really include all of group 1. There is actually another study with sotatercept in patients with what we call combined pre and post capillary pulmonary hypertension going on. So these are patients who have pulmonary hypertension due to other heart problems. The pressures on the left side of the heart are high, and so we'll get some data on those patients from that trial. To my knowledge, right now, there are not any trials in patients with other types of lung disease or, thromboembolic disease or any of the group 5 types of pulmonary hypertension with sotatercept.
Okay, so related is that when will these new drugs have an impact on criteria for diagnosis and care for PH patients? And then related to that, will these discussions be included in the next World Symposium's discussions to impact any kind of treatment algorithm?
I think that Dr. McLaughlin should answer.
Well, how about if you answer the first question and I'll answer the World Symposium question?
Oh, okay. Elizabeth, what was the first one?
The first one was whether these new drugs have an impact on the criteria for diagnosis and care in PH.
I mean, right now, in terms of the current clinical trial, they use the standard diagnostic definition for PAH. So as of now, I'm not really sure exactly if the question is more referring to the early or what we can say mild PH or borderline PH we used to say in the past, if that's what they are trying to ask. Certainly we don't know, but as we know that in the trial, we had most of the patients on dual or triple therapy, and then over and above, we treated them. So definitely, as per the current diagnostic criteria, this drug will be indicated. But what we know is that all these patients were on some sort of background therapy, and then sotatercept was added over and above that. So definitely, patients should be treated with the standard of care treatment, and then this can be added.
And the 7th World Symposium is this summer. It's late June, early July. And the working groups are hard at work already. We anticipate that the drug will be at least FDA approved. So if something is commercially available anywhere in the world, we want it to be included in the algorithm. And so at this point, the working group is discussing where sotatercept would go in the algorithm, assuming that it's going to be FDA or assuming it's going to be regulatory approved someplace in the world.
Thank you. Thank you both. So the next question is a more of a biological one, or it's talking about how can doctors measure that a PH drug is reducing the thickness in the pulmonary artery? So how do we actually make these measurements and determine whether the drug is actually working as we hope it is?
You know, this is a very interesting question. A patient asked me this last week in clinic. So far, we don't have a I should use the term gold standard technology to really measure the thickness of the blood vessel. We indirectly measure the pulmonary artery pressure. And as Dr. McLaughlin showed in the slide that how mean pulmonary artery pressure improved in the study. So which kind of indirectly suggests to you that, of course, that there is something changing in the pulmonary arterial vessel wall. There are some studies which are studying these kind of concepts, some technologies based on CAT scan, but I think that's very preliminary at this time. We need to validate those findings into bigger studies to really come up with this kind of technique where we can see if these drugs are sort of increasing the blood flow in the lungs or affecting that kind of or supporting that kind of theory. But right now, we don't have any way to really know. And of course, we cannot do lung biopsies or something like that. That's just not possible in PH patients. So.
Okay, so then the next question is maybe one for you, Val, because it's related to your talk, specifically about if sotatercept does get FDA approval, where do we see the opportunities for the new drugs that are in development, and how do we view the results from these maybe earlier drugs that are in the pipeline compared to some of the more advanced drugs that are in that development and going through FDA approval?
Yeah, that's a really great question, right? Because, we want many options for drugs, even though we're very excited about sotatercept and the clinical trial results are fantastic. It may not work for every patient. Not every patient may be able to tolerate it. It's good to have other options. And so it's really important that we continue to study other drugs as well. I think some of the things that are going to be important is allowing patients on commercial sotatercept into trials, right? And so many of these trials are going to have to take a step back and revise what we call their entry criteria to allow patients who are on the standard of care therapy into the trial. And so there will need to be some adjustments, and we'll need to talk about how long they need to be on it before they go into a trial, but there may be patients who go on it, who still have room for improvement. And then, what will the results of these drugs be on top of everything that we have now and sotatercept, the treatment effect. And so, some of them actually may be synergistic, maybe they'll work really well together. So, and then we also have to remember that these drugs, they're international studies, right? And sotatercept, I expect will become available in the US this year. It may get approved in Europe and become available in some of those countries later this year. But there are going to be many countries that don't have access to it for multiple years that are enrolling trials as well. So I think it's important for us to continue to do research because, again, choices are good, options are good. We want our patients to have many options.
Great. So I think there's a couple more, maybe we'll take a couple more questions, and in due to time. One of the questions is, are there any pediatric studies currently being done with any of these new therapies in development?
There is a pediatric study, I think it's called Moonbeam, if I recall correctly, that's going on with sotatercept.
Okay. And this is there's so many sotatercept focused questions, but so this this other question is specifically talking about that the 6-minute walk distance test was in the STELLAR trial, at least one of the endpoints that was looked at. And the question is around whether it would be reasonable to attend a baseline 6-minute walk distance test for all patients before starting the drug, and what is the appropriate, or what are the thoughts on intervals with retesting to evaluate clinical benefit?
Well, so, I mean, if you are in a regular follow-up with your PH doctors, I'm sure they have your prior baseline walk distances, and And I'm sure with each visit currently, as our guidelines recommend, that patients should be performing the walk distance. So I think you can use that as a reference for assessing the improvement with the drug. Generally, of course, the study was 24 weeks, so they assessed walk distance at 24 weeks. But generally in clinical practice, we like to see our patients back, and especially after introduction of a newer therapy, it's not only about assessing the responses, but you want to make sure that there is no adverse effect is happening to the patients. So you like to see patients sooner. So generally, 3 months period appears to be appropriate time. But if you look at that, the Kaplan-Meier curve for the walk, not Kaplan-Meier, the walk distance curve, which I showed, patients started seeing improvement after their 3 weeks interval. So it seems like the drug started working or having the response beyond 3 weeks period. So I feel roughly 2-3 months follow-up after your first initiation should be reasonable time frame to assess the response.
And I just want to add one thing to that. Like, I absolutely agree with what you said, but I just want to add that, my group has talked about it, how we're handling this. And we think it's also important to have a recent set of hemodynamics or heart cath numbers. And there's a couple reasons for that. One is to get into the trial, you needed to have a certain level of pulmonary vascular resistance. So like, that's the population we know that it works in. But the other thing has to do with, that whole risk benefit thing and what the goals are, right? So if I, have been following a patient for a few years and they haven't had a cath, I want to know what their hemodynamics are now, because their hemodynamics are pretty well controlled. I might say, is this drug worth the risk? If the hemodynamics are more advanced, I want to be able to say, this is why I want you on this drug. Or it may even be helpful. There are going to be some patients, it's come up here, I'm sure it's going to come up in clinical practice, who say, can I get off my pump, right? And that answer is going to be maybe for a lot of people, but hemodynamics are going to be really important, so, to know where you are before you started and after you started, to help decide whether we think it's safe to reduce some of those other medications. So I in our practice anyway, the heart cath is going to be part of that at the time of initiation, or to discuss it as well.
Thanks. Well, I do want to just thank both of you again very much for your time this afternoon to talk about this and share the information. It's a very exciting time. There's a lot of new promising avenues and enhancements in our understanding about the biology and medicine, and it's just it was really very interesting, and we really appreciate this. And we also want to thank our sponsors, Bayer and Johnson & Johnson Innovative Medicine, for supporting our PHA live webinars. And as a reminder, this will be recorded and posted on our PHA website under the PHA classroom videos, and available for review later on. So I hope everyone has a nice afternoon, and thank you very much for joining today's programming.
Bye. Thank you.
Thank you.